I am presenting two giant diverticulae of anterior urethra, which are very different in their approach or presentation. The first one is a 50-year-old man who was a diabetic and who had dysuria fever on and off for several years. That was more than 25 years. The urine stream was good. In fact, he had something like a hard mass in his scrotum, which he never bothered, and he thought that it's normal and maybe increasing potency. Basically, it didn't interfere with his urinary function or marital function. But by the time he came to us, he was febrile, he was toxic, and his platelets were very declining and disseminated intravascular coagulation. In fact, when we first saw him, we were not sure whether he would survive because he was so sick. He was in intensive care. The hard mass in the scrotum. We have done an X-ray, a plain X-ray of the pelvis. You can see on the top left. Yeah, this is the hard mass. This is the scrotum area, which was surprising. And when we did a urethrogram, this was below the atrium of the urethra. So it was a circular diaphragm of urethra. If you see closely, there is a leaking of the contrast from here because he had multiple fistulae over the stone and leaking some urine from the fistulae here. At the same time, the blood was filling well, the urinary stream was good, but he was sick and toxic and hypotensive. So initially we thought that first to save it, we just cut it open. We cut all the diverticule and removed the stone. This was the stone. And with that exposed thing, he was in this care for about a week. Unfortunately, he survived with all the blood transfusion, fresh platelets and all. And large laminated stone of 8.5 to 6 centimeter, the RG showed a circular diverticulum and multiple antibiotics supported care. He was discharged on SPC and 6 weeks later, he was called again for urethral reconstruction. This was urethral reconstruction. And this is the, I'll show the X-ray. This is the post-op X-ray here. You can see this is the area where this much is the sacral portion, which was holding the stone. Second patient, he had a gradual increase size of some soft tissue swelling. He was also a young man. It interfered with marital function, and whenever it passed, there was some dribbling of the urine, and even semen was dribbling sometimes because the previous quarter fluid was accumulated here. The plain X-ray was normal. You can see this is little bit smaller than the earlier one. This was not pressing on the urethra, so there was no interference with the flow of the urine. This also we cut open. This is the exterior space, and after excising the excess sac, we reconstructed the area, and post-operatively it was alright. In fact, the post-op stream, you can see this is the second case. This is the void urethrogram. So these are all congenital diverticulae which are penosmetal, excision biopsy, which showed carbon epithelium, stagnation and infection into stone formation. And preliminary SPC or diverticulae necessary in patient who had toxicity. Otherwise, straight away you can excise the diverticule and reconstruct. SPC is optional. Now, again, we used to do, nowadays we just reconstruct after excision. This is also good enough. Putting a pharyngeal catheter for 5 days is good enough in the elastic catheter. There are excellent results. In the literature, this was the largest anterior diverticule in the world, sir. Earlier reported was 3.54 centimeter. Ours was 7 into 8.5, which is quite large. This was reported in the literature. Thank you.
So the second case, did you do a cystoscopy? It was not convincing that it's a diverticulum.
I'm sure, yes, sir. Can you go back on the slide? Can you go forward? This one, sir. This one. This one, actually, there's a faint line here, sir. If you see, there's a faint line here. This is a sac. We are not done a cystoscopy, sir. But as it is emptied now, there is a line here which showed this is filling from a small gap in the distal portion. It was filling reverse like that. So we didn't need to do the endoscopy. We just open it up. Ultrasound and showed that bladder is normal, filling bladder. And as we were avoiding, this was filling. So that was enough evidence to say that this is a diverticulum on the urethra and no bladder pathology was suspected or documented.
No, the moment sir you open the perineum,
Yes.
It doesn't look like it's so much boggy compared to the first case which is distal large.
Yes.
That is well accepted.
Yes.
So about this, the proximal penoscrotal, probably congenital most common is penoscrotal.
Yes, this is also connected. This is the pulsar. This is the entire thing is a diverticulum. This is a diverticulum. When you cut here, you can see the
Okay.
This is the full calculation.
So what type of reconstruction you
No,
done?
we excise the excess one. That's called corpse collar, sir. COPD, corpse collar.
Oh, that's
Excise
it.
the entire. Whatever necessary for linear reconstruction only we keep. So bit by bit we do because we got more, there may be stricture. So we little bit more than necessary so that even some scar occur later also there should be no reconstruction in the urethral passage.
So regarding the first case, there is a multiple fistulas, what you said.
Yes, sir.
So what was the reconstruction you contemplate in this case?
Now,
Initially you opened up, you given for secondary healing. Later on, you covered that raw area with what?
no, we didn't cover it up, sir. We only put software today. We just because when we cut this open, the patient was sick. Patient was toxic, so we just left it open so that whatever infected material is it will drain. And after 1 week or 10 days, when it became normal, we put a suspicion discharge. We reconstruct after 6 weeks of discharge in the second time. By that time, this has become little bit thick, inflamed and all. So fortunately, this portion, what is near the urethral portion, was okay. But the urethra was the diverticulae was very thick and soggy, which was expected, sir.
No, you make it as hypospatic urethra finally, or you just cover the urethra after 2 or 3 weeks of delayed
No,
closure?
we reconstructed normally, sir. Normally, we just reconstruct normally.
Okay.
The post-operative X-ray.
So you excise the fresh agents and you cover it. There is no substitution.
No substitution.
No substitution.
There is excess full.
Yeah, that's what. Because he was in a sepsis.
This is the post-op of the large fracture diverticulae. This is the post-operative X-ray.
Oh, you okay.
After the 6 weeks of initial exteriorization.
Thank you.
Thank you.